Right. Yes. Keep adding. Amen. So, good evening, one and all, respective faculty members and dear residents. So, on behalf of ISMPO, I welcome you all to this month's journal club. So today we'll be discussing the paper on SWOG S1826 trial, the role of nivolumab plus ABD in advanced Hodgkin's disease. So it is having a practice-changing implication with the advent of generic molecule. This will be available to vast majority of our population, being a game changer in the field of Hodgkin's lymphoma. So it is our extreme honor and delight to have an expert panel of faculty members with us, starting from Dr. Reena Nair, Madam. She was a former HOD consultant of clinical hematology at Tata Medical Center. Dr. Harimanan Sir from St. John's, Bangalore. Dr. Krishna Kumar Ratnam Sir, HOD, Meenakshi Mission Hospital, Madurai. Dr. Sugit M. Thambi, additional professor at Regional Cancer Center, Trivandrum. Dr. Stalin Bala Chaudhary, sir, from Mahatma Gandhi Hospital, Vizag. All these experts are passionate in hemato-oncology, working a lot and contributing to hemato-oncology. And today I'll be briefing the outline. First, we'll be having a brief study description by our DRNB residents, Dr. Sara from Yashoda Hospital and Dr. Anishwar from Manipal Hospital. They have volunteered themselves to present this. So I appreciate you for coming forward, and also followed by this, we'll be having a expert review and commentary from our panel members, followed by an open discussion. And a lot of senior faculty members have also joined in. So we would appreciate your contribution as well for during this open discussion, and then we'll be concluding it. So without much wasting of time, we'll directly go on to the presentation. First, Dr. Sara Parveen will be presenting the trial outcome, the initial parts. Go on, Dr. Sara.
Good evening, esteemed faculty members, mentors, seniors, and colleagues. Today I'll be presenting the study about nivolumab plus AVD in advanced stage classic Hodgkin lymphoma. Outline of the study will be definition of advanced Hodgkin lymphoma, treatment paradigm prior to the study, and need for the study, trial design, patient criteria, endpoints, response assessment, and statistical analysis. Coming to the introduction, the definition of advanced Hodgkin's lymphoma is stage 3 or 4 lymphoma with B symptoms or bulky disease of more than 10 centimeters. The primary chemotherapy used for advanced stage Hodgkin lymphoma is MOP and COP, Stanford 5, standard BCOP, escalated BCOP, and ABVD. Prior to S1826, BV-AVD brentuximab vedotin plus AVD was proven to be superior to ABVD in Echelon-1 trial. BRCAD has also been used for selected fit patients of less than or equal to 60 years with adverse prognostic factors. Excuse me. With advanced stage classical Hodgkin lymphoma with adverse prognostic features. And for brentuximab vedotin, Rathel protocol is acceptable. In Rathel protocol, if complete response after 2 cycles of ABVD, patient will receive 4 cycles of AVD. Sequential BV-AVD followed by BV has been used with the overall response rates of 82% after 2 cycles and 95% after 6 cycles of AVD. The Echelon-1 trial was conducted with 1,334 patients assigned to ABVD or BV-AVD. They received 6 cycles of therapy And the overall survival was 93.9% with brentuximab vedotin plus AVD versus 89.4% with ABVD. 6-year PFS was also better with BVAVD. And in subgroup analysis, for patients more than 60 years, no survival advantage was found with BVAVD versus ABVD. More grade 3 neutropenia, but improving with GCSF prophylaxis was found with BVAVD. And more neuropathies were found with brentuximab vedotin AVD. In ABVD, bleomycin-related lung toxicity was found in 43% patients, therefore avoided in patients with more than 60 years of age. 18% mortality was found, and more than grade 3 neutropenia was 83%. So patients who were assigned on one trial received therapy, therefore it was not response guided. In RATHL, however, bleomycin was omitted from further treatments who achieved a complete response by PET-CT after 2 cycles of ABVD. For PET positive sites, consolidative RT versus chemotherapy was PET positive site is biopsied, and if viable lymphoma cells were found, it is treated as relapsed refractory Hodgkin lymphoma. Alternatively, RT can provide effective palliation for frail patients. For patients who have achieved complete response on ABVD, there is no role of RT as per HD0607 trial. The need for study with SWOG S1826 was a need for favorable balance of outcomes and toxicity. With BVAVD and other regimens, there is more GCSF use, and 53% of pediatric patients still need radiotherapy with brentuximab based therapies. And relapses after treatment in advanced Hodgkin lymphomas are problematic. The biological rationale is Hodgkin lymphoma is an immune evasive tumor. So PDL1 blockade is promising since it has high expression on the HRS cells due to alterations of PD1 ligand genes on chromosome 9p24.1. So unlike brentuximab vedotin, which targets CD30, PD1 blockade directly targets the disease biology, proven effective in relapse refractory setting of Hodgkin lymphoma. In the older patient subset also, these patients have difficulty tolerating chemotherapy, and they often receive lower doses and fewer cycles because of this. So also the treatment related mortality is higher in this subset, and they have lower survival rates. So Nivo AVD is better tolerated than brentuximab vedotin AVD. Coming to the methods, this trial was conducted by SWA Cancer Research Network in collaboration with COG across 256 centers in USA and Canada. This is a international randomized open label phase 3 trial. The patients were inclusion criteria included patients more than or equal to 12 years with the newly diagnosed stage 3 and 4 classic Hodgkin lymphoma with no end organ minute and LVF more than 50 and bilirubin less than or equal to 2 times upper limit normal, AST, ALT less than 3 upper limit normal, and no ILD, pneumonitis, active autoimmune disease, or no peripheral neuropathy grade more than or equal to 2. Patients were stratified by age 12 to 17, 18 to 60 years, or more than 60 years, and IPS stratified by IPS 0 to 3 or 4 to 7, and end of treatment RT, whether intended or not. So the two arms were nivolumab 240 mg day 1, day 15 with AVD day 1 and day 15 for 6 cycles, 28-day cycles with the optional GCSF. The number of patients in arm A were 496, and in arm B there were 498 patients. Brentuximab vedotin with AVD was given. Brentuximab vedotin 1.2 milligram per kg day 1 and 15, with AVD day 1 and 15 for 6 cycles, 28-day cycles, and here GCSF was mandatory. Uh, End of treatment RT was optional at physician discretion if residual FTG avid lesions were found. Primary endpoint was PFS, and secondary endpoints were EFS, OS, and end of treatment CMR rate and patient reported outcomes. Trial design, we have already just discussed this. And dexrazoxane was optional, and 25% patients in both arms received it. Exclusion criteria were patients without pathological confirmation of Hodgkin lymphoma, active autoimmune disease, pre-existing interstitial lung disease, or peripheral neuropathy of grade 3 or higher. Endpoints, PFS from randomization to first observation of progressive disease or death, and secondary endpoints, incidence of adverse events, overall survival, and event-free survival. Response assessment was done at baseline and end of treatment, 4 to 8 weeks after completion of systemic therapy. Additional response assessment was done for patients receiving radiotherapy. Preferred imaging method was PET-CT, and if PET-CT was contraindicated, CT or MRI was acceptable. CT was performed at 1 year and 2 years after randomization, and assessment was done according to the 2014 Lugano classification. Statistical analysis, the primary objective was to assess PFS in patients who received Nivo-AVD as compared to those who received BV-AVD. The randomization was 1:1 across the three stratification factors, that is age, IPS, and end of treatment RT received or not. And based on previous data, 2-year PFS of BV-AVD was estimated as 84%. And exponential cure rate model assumed that is 70% of BV-AVD and 74% Nivo-AVD group would have no disease progression or death in long term. So among patients with disease progression, hazard ratio 1.67 for progression was assumed. Power was 86% to detect a 6% difference in PFS. Final analysis was done at 179 events across both groups. Interim analysis was done at 3 points, 25%, 50%, and 75% of anticipated PFS events. Modified intention to treat analysis performed were excluded in accordance with SWOG policy. And at 50% fraction interim analysis, this was done on December 2022. Primary results were reported because PFS crossed the threshold of p-value of less than 0.005, and 70% fraction analysis was done in March 2024. Thank you. The further results and discussion will be done by Dr. Anishwar.
Thank you, Dr. Sara, for that elaborate presentation. Moving on to the next part of the trial, design, the results, and the conclusion, I invite Dr. Anishwar, first year DNB resident from Manipal Hospital, Bangalore, to present.
Good evening, everyone. You are able to see my slides.
Yes, your slides
Yes.
are clear.
Yeah, yeah. Yeah. Good evening, everyone. So I'll be continuing with the following. First is coming to the characteristics of the patients. So the median age was around 27 years, and the distribution of age groups was wide range from starting from 12 to 17 years, 18 to 60 years, and greater than 60 years. A majority of the study population was from 18 to 60 years of age, and the race and ethnic group was majority of the study population were whites, and disease stage, which included both advanced stage, stage 3 and stage 4, and with 62 to 65% of on the population were around in the stage 4. And coming to the IPS, majority of the study population had an IPS of 0 to 3, and also included bulky disease and HIV positive status. In the steady stage analysis, 487 of 496 patients in Nivo AVD group were included in efficiency analysis. So, whereas 482 out of 487 patients were included in safety analysis. So, when compared with BV AVD group, 483 out of 498 patients were included in efficiency analysis, and 476 out of 483 patients were included in safety analysis. So both groups had a similar number throughout the study with minor differences in exclusion. Coming to the results, so the study has shown a 2 years estimate for progression-free survival of 92% with Nevo AVD group when compared with 83% in BV AVD group. So the results, PFS benefit of Nivo AVD group was sustained with the 3 years follow-up, which has shown Nivo AVD had 3 years progression-free survival of 91% and BV AVD group of 82%. And response across different age groups. So Nivo AVD prolonged PFS in adolescents with the 3 years PFS of 93% when compared with 82% in BV AVD group. And coming to older adults, so 3 years PFS was 82% in UAV with 58% in BVAVD group. So efficiency sustained with longer follow-up with a median follow-up of 2.5 years, 2.1 years, and 41 events with disease progression or death in Nivo media compared with 8 in disease progression in the form of disease progression or death in VVAPD. So rate of nivolumab was not transient. Coming to the overall survival trends, the data is immature, but the trends favor Nivo AVD with 2 years overall survival more or less equal in around 98 to 99% in both the groups. So consistency benefit across all the groups. Nevo AVD has shown a uh, consistency across all the age groups, including adolescents, uh, adults, and older adults greater than 60 years of age. So, when compared to coming to the superiority for AVD, when in the stage 3 and stage 4, the hazard ratio is around 0.45, and in IPS score of 0 to 3, and higher IPS score, hazard ratio was around 0.46. Uh, Showing Nevo AVD was effective even in the high risk population, like stage 4 and higher IPS, reducing the fear of undertreating severe disease. And coming to the event-free survival, event-free survival was favoring nevo
Anything be done to improve the audio?
time to progression, relapse, death, or initiation of non-protocol therapy was higher in neo-AVD group with 90%, with a hazard ratio of zero point 0.5. So,
Dr. Anishwar,
and
Dr. Anishwar, just a
there
second.
was a
Dr. Anishwar,
drastic reduction
Dr. Anishwar,
radiation use. So then total omission of the consolidation compared with other historic pediatric protocols and HT21, that is BRICAD. New AVD group had, especially peripheral neuropathy, was significantly lower toxicities and GCSF use. The neutrophil greater than 3 was more present in BV-AVD group. So GCSF was optional in New AVD. Coming to the sensory neuropathies. Yeah. You're able to hear me, Nuka?
Even your, I think that.
Oh, okay.
That-
I'll just wait till
Dr. Anishwar,
yeah.
are you connected
Yes,
through
sir.
your Wi-Fi or are you connected from your telephone, your mobile phone internet?
Yeah.
Because I think your signal is very
It's from
low
mobile phone.
because your voice is absolutely breaking and we are not able to hear. The bandwidth is too low for on your side. Can you slightly maybe change your position, or if you are within some room where you are not getting your signal?
Yes, I'll just try to adjust it.
Now you're audible, Anishwar. This position, you're audible.
Yeah, whatever you spoke now at this particular
Audible.
position, you were audible a bit. So earlier only, I think it was not heard.
So you're able to hear me now?
Yeah, now very clear.
Yes, I'll just continue. So you're able to hear me now, right?
Again, I think as you start the presentation, there is a problem. Anyway, please go ahead.
Shall I continue? You're able to hear me, sir?
Yes. Yes, yes, please.
Shall I continue? Yeah. So coming to the sensory neuropathy, so like peripheral sensory neuropathy in Neo-AVD arm, when compared in BV-AVD arm was relatively high when compared with Neo-AVD, and grade 2 neuropathy was more in BV-AVD group. So coming to immune-related adverse events associated with the PD-L1 blockade was associated the common immune-related adverse events were hypothyroidism and hyperthyroidism. Incidence of hypothyroidism was 7%. Those in the Neo-AVD group when compared with BV-AVD, which was less than 1%, and incidence of hyperthyroidism was around 3%. So coming to the limitations, so the first limitation is the limited overall survival data. So, like at the time of reporting, the overall survival differences were very immature. So, given the high cure rates in advanced stage Hodgkin's lymphoma and the availability of effective salvage therapy, overall survival may take years to emerge. So, therefore, the clinical advantage is primarily based on PFS and toxicity reduction, not on overall survival. So coming to the long-term risks such as late immune-related toxicities, secondary malignancies, and cardiotoxicity from high cumulative dose of doxorubicin doses cannot yet be fully assessed. This is especially relevant because Nevo-AVD uses a high anthracycline dose than many other pediatric and BioCop-derived regimens. So, and coming to radiotherapy de-escalation limits generalizability. So end of treatment radiotherapy was used in less than 1% of the patients. It is a major strength for late toxicity reduction, but may not reflect the real world practice in all regions or risk adapted protocols. The finding may not directly apply to the settings where PET adapted radiotherapy remains standard. So the control arm which was used was BVAVD and not ABVD, limits direct comparison with the long standing global standards, making it difficult to quantify how much of benefit is due to nivolumab versus avoidance of brentuximab toxicity. So cross-trial comparison with the ABVD must therefore be interpreted cautiously. So as it is an open label trial, this study was not blinded, reporting bias from the subjective toxicities, example, fatigue and neuropathy, and differences in the treatment discontinuation. So while endpoints like progression-free survival or objective, toxicities assessment may still be influenced. So, and coming to the laboratory neutropenia was more frequent in Nivo AVD arm. So although the infection rates were not increased. So this finding requires careful monitoring in the real world setting. So, and one more is like all patients receive PDL1 blockade regardless of degree of 9p21 amplification and PDL1 expressing levels. So the absence of predictive biomarker limits the precision therapy and may expose some patients to unnecessary immunotherapy. As nivolumab is substantially more expensive than the conventional chemo, cost effectiveness analysis and accessibility is in low and middle income countries remains unresolved. So even though there are no head-to-head comparison trials between Bricard and Nivo AVD, a matched adjusted indirect treatment comparison was done in a population with advanced Hodgkin's lymphoma treated with in the frontline setting. So comparing this Bricard and Nivo AVD, so the better Bricard had was primarily a PET response adapted, and the duration of therapy was only 3 months, whereas they have got a progression-free survival and overall survival data for 5 years. And like GCSF was also mandatory in Bricard regimen. So anthracycline dose was relatively low when compared with UAVD, and major toxicities were hematological toxicities in the Bricard group. So onset of adverse events were immediate and the duration of adverse events were short lasting, and there were almost no contraindications, whereas Nivo AVD was not it was not a PET response adapted, and duration of therapy was for 6 months. Progression-free survival and overall survival was only for 2 months. And GCSF was not mandatory, whereas the dose required, anthracycline dose was relatively high in Nivo AVD group. And major adverse events which were noted in Nivo AVD group were febrile neutropenia, immune-related adverse events, and onset of adverse events were even delayed. Duration of adverse events were prolonged, and the contraindications included autoimmune and other immune disorders. So concerns, coming to the concerns regarding the immunotherapy, especially Nivo AVD. So like there are many articles like in the blood also has mentioned the feasibility and safety of anti-PD-1 as a first-line treatment for classical Hodgkin's lymphoma. So do we really see the full picture? So, like, are we really addressing the long-term complications of the immunotherapy, as immune toxicity is a multi-organ threat, which is involving endocrine, hepatic, dermatological, neurology, pulmonological, and gastrointestinal musculoskeletal system. And even the blood also has emphasized in articles like immune thrombocytopenia in patients treated with immune checkpoint inhibitors, and even clinical spectrum and evaluation of immune checkpoint inhibitors toxicity over a decade. And multiple journals from Frontiers and the new NEJM have also emphasized the immune-related adverse events from immune checkpoint inhibitors and even delayed immune-related adverse events with the PDL1 based immunotherapy in melanoma patients. So, and even like persistent immune-related adverse events after cessation of checkpoint inhibitor therapy, like the prevalence and impact on the patient's health-related quality of life. And also concerns regarding incidence of diabetes mellitus in the patients treated with the immune checkpoint inhibitor therapy as in comprehensive cancer care experience. And even ASH has also published potential delayed immune-related adverse events in the patients treated with frontline pembrolizumab and AVD for classical Hodgkin's lymphoma. And fertility and gonadal functions after first-line treatment with Nivo-AVD in Hodgkin's lymphoma patients. So, and even Journal of Immunotherapy has emphasized on immune checkpoint inhibitors-related hypogonadism in infertility and neglected issue in immuno-oncology. So, the toxicity does not end with the infusion. So, like the toxicities can be delayed onset, having persistent side effects and chronic management in the form of hypo and hyperthyroidism. So current data is insufficient to stratify the risk and the evidence gap with long-term in the form of long-term curative context. So uh, uh, before broadly adapting to the PDL1 based regimens to shorter treatments of to 3 months, most of the communities require harmonized reporting, comprehensive tracking, and long-term follow-up as a standard of care. So, in a highly curable disease, it's like Hodgkin's lymphoma, the tolerance for chronic morbidity is low. So, relatively impacting the quality of life, fertility, and organ function. Right.
Thank you, Anishul, for that excellent presentation. Sorry for the technical glitch that happened in between due to unstable network. So moving on to the next session, we have expert review and commentary by our expert panel members, Dr. Reena Nair Madam, Dr. Harimanan Sir, Dr. KKR Sir, Dr. Stalin Sir, and Dr. Sugit Sir. Over to you. Madam, can you please take over?
So yes, we thought Hodgkin's was cured by ABVD and we were doing well in Hodgkin's, and then suddenly this change of drugs, the brentuximab came in first and then Nivo now. I think the presentation and the discussion post the presentation has given us a fair idea that when we go into new drugs, we should be a little careful. He has covered the known and the unknown toxicities well. I uh, would think that if we have, we can, now be more selective in our patients, depending on uh, what is the best way to cure them, remembering always that using the best drugs upfront may still not be a good idea because we have reasonably good controls with the second line in Hodgkin's. So, my first request to everybody is that don't forget ABVD. It still cures a lot of patients in stage 3 and 4. And rather than having patients drop out of treatment in a very curable disease because of costs and the cost implications, have a detailed discussion and see that the standard of care and its cure rates are available to all patients. Having said that, definitely we like to do better for some patients, especially if they have a lot of B symptoms, they have extramedullary disease, and they have a high score in stage 3 and 4, or they have a very large bulky disease in stage 2. And brentuximab trial has had an impact for a pretty long time. The 7 years data, I think, is also out. And after 5 years, it has started showing an overall survival benefit in patients. However, having said that, brentuximab is not an easy drug to give to patients, especially when you are giving it every 15 days. There is a lot of toxicity, a lot of supportive care is required. And so, with the costs, consider the cost of the supportive care also. Nivo AVD has shown excellent results in progression-free survival, no doubt, as we have seen in the survival curves today. It is going to take time to show any, if at all, overall survival benefit for the simple reason that the second lines are extremely good. And the cost at the moment is something we have to think. However, if we have to choose patients from precision medicine, I think the first subgroup which shows excellent results is the older subgroup in whom cure rates have always been very low with drugs like adriamycin and bleomycin. So that is a group where definitely you can consider these newer regimens, especially if cost is not an issue. This is, I think, the first time that the pediatric group has come together. We have pediatric patients being given adult like treatments, and they also seem to be doing reasonably well. And the need for radiotherapy going away from children is something I think which will make a lot of impact, if not immediately, in the next 10 to 15 years. So, having summarized whatever was told to us, I think the rest of the faculty can make their own points and then we can take questions from the students and the audience. Thank you.
Thank you, ma'am, for those insights. I request Dr. Harimanan sir to give your perspective on the trial and your expertise.
I think Krishna Kumar is there, Dr. Sushil.
Yes, yes, ma'am.
Baba is there. I think all of you all can make comments. We'll find Hari.
Yes, ma'am. Krishna here, ma'am.
Yeah. Thank you.
Thank you. Oh, Hari sir, please go.
Yeah. No, so I think what we need to understand is uh, what we need to have maturity when we interpret these studies and not just look at the numbers. Uh, Definitely, the SWOG 1826 is very impressive. But if you ask me, it was bound to succeed because when you technically look at chemotherapy, if you look at the brentuximab AVD regimen, it's a pure chemotherapy-based regimen. There's no immunotherapy, and we know that Hodgkin's lymphomas, it's exquisitely sensitive immunotherapy due to the biology of the disease and because of its immune evasion that is key to the survival of the Hodgkin's lymphoma. So it's no great. I would say it's not a great surprise for us to find that uh, uh, kind of improvement in outcomes and including the early responses that we see, which seems to be sustained in the 3 year follow up of these patients. But as Madam rightly said, and that's what when I say maturity, we should never forget the ABVD regimen, which wherein we are curing a huge number of patients. What we see currently is, especially in early stage Hodgkin's lymphoma, we are looking at improving outcomes in patients who have more than 90% or close to 95% long-term outcomes in these patients. So we have to be cautious about the long-term side effects of these immunotherapeutic drugs, and we have seen in patients in real world when they use immunotherapy drugs, they come out with some unique problems which are difficult to overcome. So we should be judicious about implementing. No doubt about the fact that it's a well conceived study, it's a well balanced study. It is actually had all its, I mean, subgroups reasonably well balanced. I would not say completely well balanced, but reasonably well balanced. And also the concerns about long-term toxicity may be valid, but then we are talking about the presenter did show several of these long-term challenges that we face with immunotherapy. But one must remember those challenges are mainly faced with immunotherapies that were given for 1 year and 2 years. In this particular case, in this study, it was only used for a limited duration. So it will be interesting for us to understand the long-term outcomes. But my feeling is that we may not have too much of immune-mediated responses, though we do understand many a time these immune-mediated responses may be idiosyncratic. And if that is the case, you're likely to encounter these much earlier in the phases of treatment than much later in the treatment. So that's one point. And also the limitations of the study, as we say, we always want to look at overall survival, but these days most of the studies are designed to look at the progression-free survival because you have so many second line and third line therapies that will negate this the improved overall survival that one may think will happen with the first line therapy, and in this case, nivolumab. So I feel that we're unlikely to get that kind of a long-term survival. But again, one of the other impressive thing is the decreased use of radiation over here, which is quite impressive because we all know that radiation has its challenges, though the current techniques will decrease those chances considerably, but at the same time, decreasing the use of radiation is going to go a long way in decreasing long-term toxicity, especially in women who have mediastinal disease, and where we hesitate giving radiation to these patients as far as possible. And the third point, as Madam rightly said, in the elderly patients, this seems to be a good option. And I would though we know from historically that anthracycline is probably one of the most important drug, we know that dose density matters and giving higher doses does matter. So I would like to see whether we would be able to reduce the doses of adriamycin in the elderly population, which is always a challenge when we're using ABVD in the elderly patients for their treatment. Good study, but always take it with a pinch of salt. Don't get swayed by the results. Be judicious about implementing this regimen in saying that you give it in all comers, which is probably not the right thing. And especially now that we have nivolumab in the generic formulation, which is much cheaper, the temptation is to use it, but be judicious about using it. Definitely one of those studies which is going to always be highly quoted and going to be a benchmark for future trials, but it's always difficult to improve the outcomes in Hodgkin's lymphoma with the existing lines of therapies. And so it's always going to be surrogate endpoints that is uh, 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 going to be considered as outcome data for newer drugs that is going to come in the future. Thank you.
Thank you, sir. Thank you for sharing your practical points on Nivo ABD. Now we have KKR, sir. Sir, can you please take
Good
over?
evening. Good evening. And I think Professor Reena Nair and Dr. Hari Menon, their pearls of wisdom, I think, has covered everything. So probably just to add, because this was a journal club, so I was also trying to read and then try to find the methodology and the statistical analysis and then certain critical reviews, trying to go through that for the S1826. So as I think Dr. Hari already mentioned, see, trying to have an early analysis, when the trial, the efficacy at 50% at information, when you are really trying to analyze, there could be a small inflation factor. Things may look very big to start with. And as Dr. Hari beautifully mentioned, as the as you start following up for long-term data, because the median follow-up is at 2.1 years, the hazards may actually, the ratio may start to narrow. So we have to see, because for any study, the survival is going to be the first thing which we would like to consider. But apart from whatever ma'am has said and whatever Dr. Hari has said, avoiding radiotherapy and avoiding, and the using a short course of Nevo is not going to be too much of a long-term issue. So that may not be a real concern. So that is one more point. So I also totally support finally with what ma'am says, and because this Nivo and the Pembro and all these came in the relapsed and refractory setting to start with, and since we've salvaged so many patients who have failed even BACOP, they've failed even ABVD, and they've been able to salvage them with immunotherapy. Sometimes you have this save the best for last approach. So said that, if you want to use, I think in my practice where bleomycin cannot be used, the elderly subset and those with the high Hassan Clever index, and you have a very high burden of disease where the ABVD is is inferior, and BACOP in many of our settings, the escalated BACOP is not practicable. I think in that situation, the Nevo ABD would probably become helpful. And said that, the BRCAD, we had a handful of patients on BRCAD. They've had wonderful responses. And then, the responding ones have a very short course, it's just 4 cycles. So that way, it is also not so bad a regimen to use. So in today's context, for the standard patient who just walks in to your OPD, I think still we are not going to jump and start using the Nivo AVD except for in the special settings. I think that would be my thought on this study. Thank you.
Thank you, sir. Now I invite Dr. Suki Tambe from RCC Trivandrum to give you valuable insights on the. Sir, are you there?
Am I audible?
Yes, sir. Yes, sir.
Yeah. Thank you, Tina. Thank you, Dr. Sarah and Dr. Anisha, for that wonderful presentation. Like all the panel experts has mentioned. The question is like we have listened to the trial. The question is whether is it a practice changing? The answer is yes, probably it is a well conducted study, even though it is not blinded, it is a well conducted study. But the important question is whether you are going to give Nivo AVD for all the advanced stage Hodgkin's lymphoma coming to your clinic. But probably when we have this data, we may need to counsel the patient. But in practice, most of us, especially in a government center like ours, we are using APVD. But we have patients who have received new AVD. 6, 7 patients now received new AVD, and all attained CR, and we have not used radiation. And especially as Dr. Krishna Kumar has mentioned, the elderly population, and it is very difficult to use bleomycin and even brentuximab because of the toxicities. Suppose the patient has bleotoxicity, even after 2 cycles, the patient may develop bleotoxicity. And once the patient develops out of 100, the mortality is between 10 to 20. It, unlike rituximab induced ILD, the bleomycin induced ILD is a nasty thing. So in that group, maybe we may tend to use nivolumab, and we have used nivolumab, even not the full dose, but not the standard practice. Still, the response is excellent in patients, especially elderly patients. So we have experience with using Nivo and Pembro along with chemotherapy in refractory. So we have presented the data on ISOCON at Chennai. So 13 patient primary refractory, all with Nivo eyes and all attained CR and 9 received transplant. So in salvage setting, yes, definitely we can combine Nivo or Pembro with chemotherapy and we can consider for transplant. But in first line setting, remember we may use Nivo, we can counsel, but it is not the standard. Still, the standard remains ABVD. And whether it is early favorable, early unfavorable, or advanced stage, all we give 2 cycles and then take PET and then proceed accordingly. So ABVD remains the standard. And regarding Nivo AVD, in selected patient, we may use Nivo AVD. And we don't have a response adapted therapy like that we have in the response adapted therapy in RATHL trial, like ABVD into 2 PET negative, whether you can go with AVD. Like that, we don't have a data for either brentuximab or nivolumab. And most of the long-term side effect, the concerns, I think Anish has mentioned. So always remember, still in our setting, in Indian setting, ABVD remains the standard. Thank you.
Thank you, sir. Now I invite Dr. Stalin Bala Chaudhary, sir, from Mahatma Gandhi Hospital, Vizag, to share his insights.
Thank you, Tina, and thank you, ismpo, for this opportunity. So my job is easy because 4 experts has given wonderful comments and their personal experience and their insights into the trial which was presented. So my take, as Sugit told, whether it is practice changing, is definitely practice changing. But it is for all comers. No, definitely it is not for all comers. Especially, I prefer it for those patients whom I will not be able to do transplant at the time of relapse, especially the elderly population. So whether the trial was conducted properly, it is conducted properly because before Nivo AVD, BV AVD was the regimen which has shown good efficacious compared to ABVD. Whether the trial is designed properly, design-wise also trial is properly designed, and the results also showed the superiority of Nivo AVD versus BV AVD. So coming to the only replacement of PV with Nivo, so definitely immunotherapy is more tolerable, less toxic compared to the BV-AVD. When you are choosing a regimen other than ABVD in terms of BV-AVD or Nivo-AVD, definitely Nivo-AVD stands better in terms of tolerability, toxicity, even with the generics, affordability also.
So it may become cheaper than the BVAVD. So when you want to use an other regimen than ABVD, definitely among these two regimens, Nivo AVD is superior in terms of all. But whether this replaces ABVD across all subsets of population in a country like India, where majority of the patients are not affordable for the nivolumab, definitely no. So definitely still as of today, ABVD holds good because we had seen excellent survivals with ABVD. Still, ABVD is the best way to go. The only caveat in the trial was, so there was no PET directed approach. So we are now, after the advent of PET, after the usage of PET, there was no PET directed approach. So especially in Hodgkin's lymphoma, so what would be more ideal approach is if you are using a costlier drug like Nivo AVD. So if you have, well, there was a PET CR. So whether the question should be whether we can omit the nivolumab and can go with AVD, because from the RATL we know that the post CR AVD gives an excellent outcome. So if that is the option, so then more economically we can offer Nivo AVD and we can use Nivo AVD in a larger scale, and it also reduces the toxicity burden. So to all, and another question is, so is really, so all patients of who are going to start the Nivo AVD will require 240 mg every 2 weekly for 12 doses. So this is the matter of concern, because 12 doses of nivolumab 240 mg will be very costly enough, especially in a country like India. Because my practical experience, I have used low dose nivolumab of 40 mg with each cycle for approximately six patients of primary refractory Hodgkin's lymphoma. So even 40 mg of nivolumab produced an excellent responses of almost near CR in all the patients. So the matter of question is whether really 240 mg of nivolumab is needed, but the trial design was like that, and the dose used was that. As of now, if we want to use, we need to use. To address this question, possibly, so there is a trial being done by Hematology Cancer Consortium, which is called LONA trial. So across all the centers in India, the Hematology Cancer Consortium is doing the low dose nivolumab in advanced Hodgkin. There is a PET directed approach included in this trial also. If the patients after 4 cycles, that is 2 cycles of ABVD, if the PET is negative, so definitely they are excluding the nivolumab. Possibly, this low-dose nivolumab study in Indian population will address more effectively so our population, and also the pet-directed approach. Possibly, once those results come, so it can be more practice changing, and we can adopt to our population also. Till then, so Nivo AVD, a good study, good results. You can use it in for certain patients, but not all. So you should not forget that ABVD still cures many patients as of today. Thank you.
Thank you, sir. Now the floor is open for discussion. Among the participants, if there are any questions, you can come forward and please ask, or if you can share it in the chat box, we shall address it at the end. Shall we take the chat box question, sir?
Go ahead.
Yes. First question is from Dr. Divyanshu Pandey. Considering strong PFS benefit and tolerability of Nivo AVD, can we extrapolate it as a PET adapter strategy after AVD failure? If any one of the panel members can take over, please.
So, Tina, if you will repeat it, then I will see the answer should be.
Yeah, considering strong PFS benefit and tolerability of Nivo AVD, can we extrapolate it as a PET adapter strategy after ABVD failure?
So, it's a loaded question. So, when will you call it a PET failure? If it is progression of disease or it is a partial response. If it is progression of disease, then you are only changing Nivo and the rest of the AVD is still there. So one has to be thoughtful about how to use the same drugs with a change only in one drug, that is Nivo. A very good strategy now, which is expensive, is Nivo and brentuximab given together in patients who relapse. They seem to be showing excellent results. And some people have started discussing that we may not even need auto transplants in these patients. But if you have given ABVD into 6 cycles, you've already given your 300 milligrams of atriamycin. Or if you have given ABVD followed by AVD, and at the end of treatment you find that there is progressive disease, I would be reluctant to give AVD. I would do something else with Nivo at that stage. Yeah.
Thank you, ma'am, for taking
So
the
I
question.
just to add to what Madam has rightly pointed out, um, when we use nivolumab as part of the treatment protocol, um, I would hesitate about. I think the reason why PET scan was not used in this thing was because sometimes interpreting PET scans in the background of using immunotherapy can be challenging sometimes because it induces hotspots in the area of the tumor because of the immune mediated responses that is there. So I suspect that was one of the reasons why PET adapted therapy was not utilized over here. And if that is the reason why what is it? That is if that is the reason, then probably for us to do a PET scan, like how we did for a ABVD after 2 cycles for a response, and then take a decision, maybe a little bit weak in terms of a strategy that needs to be adopted. Uh, Ma'am, your thoughts on that? It's just something that came to my mind.
Yeah, Hari, the thing is that if you look at the data and you see what happens to PET positive patients, if it is a regimen like ABVD, then your outcomes for those patients is as 60%. If it is for other regimens which are PET positive at the interim, then you know that the outcomes are, at max 80. But whereas when they have looked at PET positive and the outcomes at 3 years, there's not much difference between
Yes,
PET negative and PET positive.
right.
And what you said very rightly is we will be really confused with duals 4 and 5 in many areas which are just inflammatory and even hard to biopsy at that time. So we may end up in much more confusion if we start doing PET adapted with immunotherapy models, and that is the reason why they have stayed away. But I think off trial for brentuximab, definitely they had done the PET and they did not make it a part of changing therapy. Similarly, I think at some point of time the PET outcomes will come up. But if you look at it, the outcomes for PET positive and negative is not too much difference. It's
Not too much difference, yes.
upward of 90%. So really, why do it and be confused about
Yeah.
Thank you, madam and sir, for taking that question. Now we have a question from Padmash Kulkarni, sir. Sir, are you here, sir?
it? Go ahead. You can take the
Yes.
question for the
Yes. The question is, how would you sequence brentuximab ABD, Nivo base, and BMT?
So come again. I mean, I didn't quite get the question.
Sorry, sir. The question is, how would you sequence brentuximab ABD, Nivo base, and BMT?
Okay. So generally, the data is very clear for relapse setting, where you have the ITRA study, wherein you use brentuximab 2 cycles, followed by transplant, followed by maintenance brentuximab in these patients. But generally, if you look at sequencing brentuximab and AVD, uh, uh, patients who fail brentuximab, because as I said before, brentuximab vedotin is a pure chemotherapeutic strategy, and nivolumab giving as a salvage definitely works over there a lot better than vice versa. A person who has failed nivolumab, and then you think about giving brentuximab may be not such a great sequence to follow. And we also know that when we use nivolumab, uh, any sort of immunotherapy, including nivolumab, there seems to be a sensitization to chemotherapy for these patients. So, doing a transplant following immunotherapy like nivolumab uh, would probably get a better footing in terms of outcomes for these patients. But that's just a feeling that we have. But certainly, it increases sensitivity or the what you call the sensitivity of these tumor cells who are otherwise resistant to chemotherapy post administration of nivolumab.
So I
Thank
think like the salvage options. So once the patient fails ABVD and patient progresses, I think most of the consultants now prefer to give chemoimmunotherapy, that is combining either Nivo or Pembro with chemotherapy for 2 cycles, then assess. As Sir has mentioned, Hari Sir has mentioned, most of the this immunotherapy will make the cells sensitive to chemotherapy, and then you go for consolidation with the transplant. The question is like what to give next after, like whether for 1 year can we again continue immunotherapy. I think there is not data for that. So it will be like chemoimmunotherapy, either Nivo with chemo or Pembro with chemo, followed by consolidation with transplant, and whether we can go for the brentuximab vedotin 1 year as maintenance.
Yes. Thank you, sir. Moving on to the next question. It's from Dr. Nihanti. With the advent of using checkpoint inhibitor in the frontline therapy, how should salvage therapy be sequenced? Any role of MRD or CT guided risk adapted personalized treatment strategies?
So, doing MRD other than looking at a PET guided approach can be rather difficult in Hodgkin's lymphoma because of the paucity of the tumor cells actually in the tumor. So, I don't think MRD other than radiological approach is feasible in Hodgkin's lymphoma, especially I mean, doing a PET scan over here, which is the closest that you can get to an MRD assessment. And as I had mentioned before, the sequencing of therapy should always be preferred sequence would be brentuximab vedotin if you're using that, followed by immunotherapy, and not probably vice versa.
Yes. Thank you, sir. Next question is from Dr. Raghu Vamsi. In case of patient has cardiac compromise, then how should we proceed? Should we spare only doxo or any other regimen is preferred here?
So there has been various combination regimens with especially in the relapse setting uh, for combining immunotherapy with, for example, even if there is sufficient time to a relapse for the patient, combining with DTIC or dacarbazine is an excellent option. And you can combine it with GDP, gemcitabine, and cisplatin is also an option over here. But the favored option, of course, in early relapse patients is still to combine with an anthracycline. But your point is well taken. In cardiotoxicity, if there is cardiotoxicity, you have various other options like a gemcitabine-based regimen, or even for that matter, using to some extent, though bendamustine has not been used in combination with nivolumab. There's really no data, but it is there always when combined with brentuximab. The BBT regimen is something that is an acceptable regimen. But they're using the Bejaev regimen, which spares the anthracyclines over there, is an excellent regimen. In fact, in the relapse setting, it's got one of the best responses.
Thank you, sir. There's another question on can we use AVD plus Nivo in early stage also as it is producing good results in the advanced stage? Role of Nivo AVD in early stage.
Yeah, can I take that question?
Yeah, yeah.
Dr.
So
Sorry. Hari sir, please go ahead.
No, 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 no. I was just keeping quiet. I thought one of you
Yeah,
should
yeah.
take that
Because I
question.
think
Yeah.
once again, in early stage, since results are so good with ABVD, unless there is an absolute contraindication to bleomycin, or let us say the patient is a very elderly patient for whom you feel bleomycin is going to be, very risky, I think that would be the only indication. Otherwise, as I think Dr. Hari has reiterated many times, that you have a very good drug like brentuximab, and then you have a Nevo to follow. I think we should still stick to ABVD in early stages. And I think, Hari sir, your thoughts?
No, no, absolutely. I wouldn't uh, for a stage one and stage two, which we are talking in terms of excess of 90%. I think and well proven toxicity profile and abbreviated chemotherapy, which is well established. I don't think it should be a concern for us to be using anything else other than ABVD. But of course, if you're looking in terms of abrogating the use of radiation over here, well, that answer remains. But then, even the dose of radiation is extremely small.
Thank you, sir. There's one more question from Dr. Raghuvanshi. Is there any situation where brentuximab is preferred than Nivo?
In the exclusion criteria, we saw that patients who have uh, interstitial lung disease, if they have immune disorders, that is a definite contraindication. You would not like to use it, and that's perhaps where brentuximab can be used instead of Nivo.
Thank you, ma'am. Any role of starting brentuximab in a highly symptomatic patient with high burden of disease, because immunotherapy can cause initial pseudoprogression? Will it be helpful in starting brentuximab in those set of patients, madam?
So I'm quite impressed with the questions, but I think our very simple drugs have been quite good in the pre-phase in patients who have a lot of tumor load. And in Hodgkin's, we really don't worry so much about tumor lysis. So if you really want to bring down the disease, everything including steroids in a large mediastinal mass is good. So you don't really have to take on to these drugs immediately. We can still use our standard of care. And then depending on the risk to this patient, take a decision if we want to add either Nivo or Pembrolizumab to the upfront regimen to get the best response rates, the best PFS. And of course, if it is overall survival, definitely there is an advantage over ABVD, provided the patient can afford. So please be very cautious of the fact that new drugs are available. They're easy to give. Immediate side effects are less, but toxicity is huge in terms of wounds.
Thank you, madam. We have one more question, I think, from KKR sir. If fall positivity issues are there, does it mean CT can be used instead of PET CT for Nivo AVD based regimens?
So this is interim or end of treatment?
Both, ma'am, because Dr. Hari was talking about the hotspots and the other false positivity issues. So, especially in interim, if there is going to be an inflamed environment, would the typical IPET apply in patients for whom, although in the study, the SWOG study, they used, most of the patients used the PET scan. But what are your thoughts, ma'am? Have you had patients with persistent positivity, both in interim as well as at the end of treatment? Yes, want to hear your thoughts on that.
There is a lot of confusion with the PET, both IPET and if you do the end of treatment PET very early on after the treatment is over. But if you wait for 2 to 3 months, then most of the inflammation settles down. And perhaps that end of treatment PET is an ideal end of treatment PET. And changing the treatment too early after a IPET positivity, even if it is dual 5, it is not the best thing with these new molecules because most of it is inflammatory. So you have to be really careful before you call a person progressive disease. And so under that circumstances, rather than create anxiety, unless you are part of a trial, I would say your approach is good. All that you want to see is that the tumor is not really increasing in size. You're not worried about the activity inside the tumor. And so if you have to do interim, a CT scan, or any methodology to know that the tumor has reduced in size, and do the end of treatment PET with a reasonable gap after the last dose so that all the inflammation settles down. So IPETs perhaps are not the best thing with either brentuximab or Nivo, and you end up doing a lot of unnecessary biopsies in these patients, which invariably come as inflammatory, which is kind of delays the further treatment also, and it is not so comfortable to patients who would otherwise be in complete response at the end. So you can avoid the IPET part of it for certain.
Madam,
Thank
just to
you.
add, I think from the patient that we have given Nevo AVD, most of them, I think, as Madam has mentioned, the size reduction is definitely there, but not really we are looking at the devil score. Most of them had 3 or maybe 4, but still we will continue the same. Unlike the other APVD, we won't act at this point. Probably we'll continue, and the end of treatment, we give time, take a PET, and see whether the patient is in CR. Thank you.
Thank you, sir. Dr. Raghuram has asked any ideal duration, so the ideal time period to take a end of treatment PET in the post immunotherapy setting.
So I would just say a little later is better than an early end of treatment PET. I know everybody is anxious at the end of treatment, and sometimes we do it early. If you can wait for 3 months, it's fine.
So, generally, when we are doing, irrespective, even when you use the ABVD regimen, if you are doing an end of treatment PET scan, I generally prefer to do it anywhere between 8 to 12 weeks after the treatment is completed, provided, of course, clinically you have no suspicion of any disease activity.
Thank you, sir and madam. There's one more last question from KKR, sir, about the role of maintenance IO in the post salvage setting. Patient is in CR. Any experience with maintenance IO? And if so, how long do we give?
Yeah, in the non-transplant
Okay.
candidates. So we are not able to transplant for whatever be the reason, or let us say that we could not get adequate mobilization of stem cells, but the patient is in CR. I just wanted to know the experience of Professor Reena and Hari, Dr. Hari, to know how long have you tried giving maintenance IO in these patients who are not transplant candidates?
Yeah. So from our side, usually we try to push for transplant. If that is not happening, we give 2 more cycles of chemotherapy as consultation. That's all. We are not giving maintenance.
So,
The present standard is no maintenance. The only role of maintenance in a proved evidence-based is the Athera trial, which Hari mentioned. And that is for those who have post BMT patients who were actually high risk, who had extranodal disease, and who had an early progression. That means within 12 months. For the rest of them, I don't know if there is any role of any kind of maintenance, even with brentuximab. For immunotherapy, I think there is even less evidence. Hari will correct me. I haven't read much in the last 2, 3 months. So I haven't really come across much immunotherapy as maintenance. If I have to go by my experience, there are patients who have, third, fourth, fifth relapse. And then you put them on brentuximab uh, with IO, and you'll see that they go into remission despite how much ever treatment they have taken. And for some of those patients, we have actually gone on with both drugs for almost a year. They remained in remission. When we stopped one of the drugs, they relapsed. When we put them back on the 2 drugs, again, that lady remained in remission for about 3 years or 3.5 years. So this is a one-off case. If you have somebody who is very rich, then you can try something like that. She remained in remission for a pretty long time. Every time we'd stop one drug, she would relapse, and then when we put her on both the drugs. This is not maintenance. This is just what should I say? one-off case which we have had, where she maintained her disease-free status only on both the drugs continuing.
So I would sort of agree. There is really no much of our tendency to use maintenance therapy has come from the Nivo studies and the lab setting, and also the keynote studies. So that's why we have a tendency to continue on maintenance. Earlier it was 2 years, then we came down to 1 year, and then we started because of constraints with giving every 15 days like nivolumab and every 21 days of pembrolizumab, it became a challenge actually to maintain those responses. So then we started migrating to a more prolonged duration, moved from nivolumab from 2 weeks to 3 weeks to a month's duration. But I think of late, even if you have to give maintenance in the relapse setting for these patients, we tend to not exceed 1 year of treatment. Yeah, but that's not something that needs to be taken out as a standard practice. But this is what uh, we have been doing due to compulsion of our inability to make or keep the treatment ongoing because of cost constraints.
That is, I just need, I have one question. Like, suppose the patient, like, we have planned for salvage chemoimmunotherapy, 2 cycles we have given, and the PET has been taken, PET is in complete metabolic response. And somehow, because of some reason, we are not able to do the transplant. So, in that setting, are you recommending like 1 year we can give, or we may think of giving nivolumab or immunotherapy?
So I don't have a right answer for that, but if we were to do a transplant, we would stop at it. Yeah. So
Yeah.
we would give anywhere between 2 to 4 cycles of salvage
Yeah.
therapy. Now, the most popular ones is actually using a Nivo GND, using a vinorelbin-based therapy.
Yeah.
But we would stop after the transplant, isn't it?
Yeah.
So if you're not doing a transplant, maybe we would just go up to 6 cycles. But then if you're
Yeah.
using doxorubicin in the salvage setting, like liposomal doxorubicin, it can be a challenge in terms of the toxicity that can, because most of the time, many of the patients would have received ABVD. That's the only thing. So I think increasingly we are moving away from maintenance therapy.
Okay. Thank you.
Thank you. Thank you, Professor Hari and Dr. Ina. It has always been something new that we always hear and listen from people who have dwelled, in the space of lymphoma and myeloma. Thank you once again. And this, it was a pleasure listening to both of you and the other faculty from RCC, my good friend Stalin. And congratulations to both the presenters. You did a very wonderful job. And uh, to conclude, probably, I was asked to give the concluding remarks. Uh, I think ABVD will continue to be the drug of choice in early stage, as well as probably the not so high risk for like patients, what Professor Reena mentioned, because it still has wonderful efficacy with very good cure rates. However, in patients who have high risk Hodgkin lymphoma, elderly people who may have contraindications, Nivo AVD is definitely uh, a boon and a good drug that produces excellent overall response rates. And in interim, the analysis has shown that there is a very good progression-free survival advantage. Yet we have to wait for the overall survival data, but I'm quite sure that still Nivo AVD is going to have its promise for this group of patients. And limitations of the study, apart from what was mentioned about the short follow-up, it was an unblinded study, which was, since there was no central blinded review, there could have been certain biases which were related to the investigator side. So, apart from that, this is a well conducted trial, and I think it is definitely practice changing. Thank you, Tina, and back to you.
Thank you, sir, for this concluding remark. So with this, we come to the end of today's Journal Club. I take this opportunity to thank ISMPO for giving us this wonderful opportunity, and also to our esteemed faculty members, including Professor Reena Madam, uh, Dr. Harimenan sir, Dr. Krishna Kumar Ratnam sir, Dr. Stalin Bala sir, and Dr. Sukit and Tambe sir. And also to the presenters, Dr. Anishwar and Dr. Sara, their first year DNB residents who have volunteered themselves to present. I also congratulate and extend my gratitude towards them, and to all those who have attended. And special thanks to Dr. Stalin sir and Dr. Sugit sir for guiding these postgraduates during their preparation time, and giving it a wonderful way out for them. So I again thank you all for joining, and we shall wind up the session. Have a good evening. Good night.